Hello, my name is Greg Agason. I'm the Vice President for Surgical Services for Specialty Care, and we'd like to welcome you to this third event in our Masterclass series on robotic surgery. Specialty Care is a clinical services and quality improvement company that delivers exceptional care, outcomes, patient safety, and financial results in over 1,300 hospitals and health systems across our country. We support more than 15,000 physicians while they perform over 500,000 surgical procedures annually. We're the nation's largest and most experienced provider of perfusion and intraoperative neuromonitoring services. Auto transfusion and surgical assist support services are also available from us. For sterile processing, we're a thought leader, working to transform our clients' SPDs into highly reliable departments. Specialty Care has a full complement of services for SPD, including consulting, staffing, project leadership, and other support services. We're the industry's choice for solving challenging sterile processing issues. Today, it is my pleasure to introduce Josh Feldstein, President of Kava Robotics. Kava Robotics is a trusted partner company with Specialty Care. As you will hear in our third masterclass, Kava brings a wealth of knowledge and experience in improving the performance and quality of your robotic program. With that, I present Josh Feldstein.
Greg, thank you very much, and thank you all for spending a little time with us this afternoon. I look forward to introducing you to our team, and we'll be speaking a little bit about how you can create a truly optimized and profitable robotic surgery program at your hospital. This is the third webinar, as Greg said, in our series, and today we're going to get practical, and we're also going to give you some exciting case studies to give you some insights into how all of this can happen at your facility. We're joined by Dr. Herb Cousins, our medical director, Dr. Bill Skinderis, who is a general robotic surgeon and also one of our medical directors, Jim Flickema, who is a robotic program hospital administrator and a consultant advisor to Kava. And each of them will be presenting some insight from their own perspective as experts in robotic surgery and robotic surgery program management. So I'd like to start off by looping Herb into this discussion a little bit. When we talk about a kind of a baseline understanding of what best practice looks like in robotic surgery, the first point we want to make is this one, and it has to do with costs being equal to or less than lap. Herb, can you speak to this and sort of how we arrived at this insight?
Right. So minimally invasive surgery is, clearly heads and shoulders from a quality perspective and patient experience perspective better than open surgery. But over the years, it's been very difficult to parse out the subtle difference between robotic surgery and laparoscopy. And as robotic surgery grew, the issue was, the cost and the time that it took to perform robotic surgery. It took many years and many, many cases and learning curves for quality to start to be a differentiator between robotic surgery and laparoscopy. And it's even still a tough thing to prove that quality is better with one modality over the other. So if quality is going to stay the same, then for value to stay the same, robotic surgery costs have to be on a par with laparoscopy. Otherwise, there's no value in robotic surgery. So we try to use our experience and guide hospitals so that they can measure these outcomes of quality and cost, and then make robotic surgery on a par or better than laparoscopy.
One of the things that I think everybody needs to be clear on is that when you talk about quality being the same between laparoscopy and robotics, you're talking longitudinally in terms of the research that's been done. So over the course of 2 years, as an example, you're going to see relatively the same clinical result, whether a case is performed laparoscopically or robotically in many cases. However, over the short term, it's a very different story. And maybe you and Bill can talk about some of the differentiators over the short term that really are patient satisfaction components as well.
Well, it took many, many cases, and some of us have grayer hair than others on this phone call, and so we've been around since the beginning of laparoscopy. And some would have grayer hair, but they don't have any hair. So that would be it
I
lost
resemble
a
that
long
remark.
time ago. Yeah, right. So no, but we really did grow up in the learning curve of laparoscopy. And there were questions about laparoscopy early on cost and is there value in this or not? And we remember those things. And the same thing happened with robotic surgery. And so it took many years for enough cases to show the power, of statistics to say that, yes, robotic surgery has less blood loss and less risk of transfusion than laparoscopy. But those didn't come quickly. They came quickly in cases where there was no lap equivalent, like, of course, nobody would suggest doing open prostatectomy much anymore. Robotic surgery has become the standard, but laparoscopic prostatectomy was really not a procedure. So in cases where you don't have a lap comparison, robotic surgery was head and shoulders the best quality and the best outcomes. But in those where there was, like Dr. Skenderis's case as a general surgeon, like cholecystectomy or inguinal hernia, that becomes really hard to tell the difference between lap and robotic surgery from an outcomes perspective.
Bill, you want to comment a little bit on that? And we talk about patient experience, reduced pain, back to work faster. Those are some of the things and others that are notably recognized as benefits over the short term with robotics. What's been your experience as a general surgeon?
Yeah, I mean, this clearly, at least in my hands and most of us doing robotic, for example, hernia surgery at my institution and within my system, we're seeing significantly improved patient outcomes, not just in terms of recurrence rates, infection rates, and so forth, but I will say that my recurrence rate is significantly less with robotic surgery now than it was with laparoscopically, quite frankly. But I think what we're seeing, and I've had several instances and continue to, where patients come to me at the 2-week post-op visit and say, well, why did you even give me a prescription for pain medicine? I didn't even take one. They go back to work within 2 or 3 days to a desk job, or even those that have more demanding jobs doing sort of light duty at their jobs. And so I think from that standpoint alone, it's superior procedure.
One of the interesting points that we see consistently talking to hospitals across the United States is that there is the beginning of an awareness that robotic surgery might be a 24/7 service and not just from 7:30 in the morning till the 3 o'clock in the afternoon shift for emergent appies and choles. And I know to some people that's a shocking thing to hear, but we're starting to hear hospitals, CEOs, CFOs, chief medical officers around the United States recognizing that in certain cases, appropriately selected, it is sometimes a very viable path. Herb, can you speak to this a little bit?
This affects Bill a lot more because he does the acute cases, but robotics has always been looked at as, well, it's not for the simple elective cases, it's for the hard cases. Well, if that's the case, an incarcerated hernia or an infected gallbladder or a ruptured appendix, those are the hard cases that might wind up open. And so, it does make sense that 24/7 acute surgery would migrate to the robot. We talked about the growth curve of laparoscopy. No one would even think about, well, it's the middle of the night, we can't do laparoscopy. And now with robotics, I think we should be at that point where if the cost is the same and the time is the same, why not use the tool in the middle of the night?
Bill?
Yeah, I think that as Herb mentioned, you're seeing robotics really give an advantage when you're doing the acute care surgery. You're seeing the incarcerated hernias where you want to do them laparoscopically, but you're worried about injury to the bowel. And robotics, clearly, with its improved vision and its improved instrumentation, offers a significant advantage there. Acute cholecystitis as well. If you look at some of the case reports that are actually coming out in the literature, you're seeing that operative times are significantly decreasing for those acute cholecystitis cases. You're seeing that those cholecystitis cases that you might have had to open with regular laparoscopic tools can now be done with more facility and, of course, more safety robotically.
So all of this leads to the question, how do you put a best practice program together to get these types of services in place? And when we think about a robotic program, very much different from the way laparoscopy was originally conceived, it really does have its own team approach and its own ecosystem. There are many different components of it, including a programmatic approach that says, first of all, you need to have a vision as to what your minimally invasive surgical services program is going to be shooting for. And that's very important because a lot of hospitals and systems, frankly, don't have a clear vision with regard to their MIS services. And within that, what is the role really of robotics as the tip of the spear, as they say, with regard to surgical services? So vision, data analytics, and governance. Let's take a moment to talk a little bit about data analytics. And Herb, I'm going to loop you in again on this because it is something that is very important to you. And obviously you spend a lot of time as our medical director dealing with some huge databases with our client hospital systems. Let's talk about the relationship of data analytics to governance and the committee structure and how a hospital needs to be thinking about these things when they want to build a best practice program.
Right. So there's a lot of change in the way that hospitals function now with electronic medical records compared to 20 years ago when everything was on paper. So we have access to all this data, but that data doesn't really mean anything unless we take a clinical eye and look at it, or we analyze it and see what's the message behind it and turn that data into information. And a lot of time, just pure IT or administrators that don't live in a clinical world have a hard time doing that. So I think what sets Kava apart is, as surgeons, we look at that information to analyze it from an eye of what do we see in the OR and what do we look for in the trends of data, or what are we trying to change in the operating room, and use that data to drive change. And so it takes expertise both from a clinical and an IT perspective to merge those two worlds. And that's kind of our approach to looking at opportunities in the data, or to measure improvement. And there's awful lot of opinions, in committee meetings, but we try to drive it with transparent information and data.
So that means that all of the attendees at the robotic committee meeting, it has a committee chair. There are going to be representatives from the med staff, from all the service lines. There will intermittently be participation, OR crew, SPD, supply chain, and the administrative leadership has to participate. All of this brings together a group of stakeholders with a common understanding, following common principles, which we've gone over in the first two webinar series. I'd like to introduce Jim Flickema. And Jim, you are a hospital administrator, many years of experience. Maybe you could speak a little bit about your role at Munson Healthcare and your role specifically launching a program at a small rural hospital in Michigan. How did that go in terms of bringing these pieces together?
Well, in hindsight, it went really, really well. But again, we were getting into unknown territory when we brought up the idea. We were already a highly minimally invasive surgical program serving a large market area in central northern Michigan, towards the tip of the mid, as they say. We started our program when we started doing the study about feasibility, where we're going to bring it in. We knew that there was not a lot of room for error. We really needed to make this program very tight and functioning at a high level, using best practices from the get-go. to be successful. And that was our goal. That's what we did. That's what our senior administrators that gave me this task as a program and project lead from administration to do with our team. Our team was very engaged, the OR crew, the support folks in the OR, as well as the surgeons, our board of directors, and most importantly, our senior executives, our CEO, CFO, chief of nursing, all of that. And that all those pieces came together. We did all of these steps. They were critical for us. We didn't waver at all. We had a vision. We had to get the data analytics. We had a governance structure put in place. We had a committee structure put in place. We had great surgeon leadership and champions. And it is a team sport, and we had a great team. Maybe I was fortunate to have that great team, but that's how we started out, and we were very successful.
We have a case study that Jim will present a little later in our discussion today. And Kava worked with his hospital for several years, and that resulted in a peer review journal publication, which we'll also share with everybody a little bit later. So when you think about the elements of an ecosystem, these are some of the key points that Jim just touched on, Herb just touched on. Very important to consider when you think about putting a program together. Now, let's take a moment to dig into this a little bit more specifically when you think about how do you develop a best practice program. Let's talk a little bit about the executive sponsor and that project lead. That happens both from the perspective of administration. You have your med staff and the committee chair, and the role of the robotic coordinator. So I'm going to ask both Dr. Cousins and Dr. Skinderis to speak a little bit about how this functions and the importance of this. And Bill, would you like to start off?
Sure. And if I may, Josh, I just wanted to give my experiences that I had, because our hospital and hospital system actually engaged Kava as well. Basically, we got our first robot at our hospital probably now almost 8 years ago. And we were doing pretty well. We had a fairly successful program. We had several surgeons, excuse me, that were utilizing it. We had a robotics committee, but we were just sort of languishing. And one day I get a call from our administration that said, we need to revamp our robotics committee. We need to kind of get things going. It costs us too much. We're not doing enough cases, et cetera. We don't have enough surgeons utilizing it. And they brought in Kava. And what that did was allowed our robotics committee to get the medical staff representatives, and in fact, leaders such as myself at the time, to really engage not only with administration, but also with the surgeons. You want somebody leading your committee who is dedicated to the program, who really sort of believes in trying to improve the program. The Kava engagement through the committee really helped us. Dr. Cousins came down and met with us, and Herb, I don't know that I formally thanked you for risking your health coming down during the height of the pandemic. But in meeting with me, the chair, and explaining what the engagement was all about, having us with the, I guess, not necessarily respect, but having with the reputation of being able to go to the surgeons across all the different disciplines to say, hey, why don't we look at trying this? I mean, surgeons are really supposed to be fairly nimble on their feet, to be able to adjust and change procedures and so forth. And as just a real quick example, one of our other medical directors had a different instrument profile than I was using in my hernia surgery. And I tried it and I actually liked it, and my quality has gotten better. Like I said, my recurrence rate has gone down, patient satisfaction has gone up. And quite honestly, it has saved our money. But the really important thing is really that these relationships that are developed through working with administration, are really critical to developing a successful robotics program. And I think having a good robotics committee that is engaged is probably one of the most important things you can do for your entire program.
Yeah, and I appreciate that, Bill. And I'll add a couple of comments that is the last bullet point, the lean instrument profiles. As surgeons, we're kind of the largest, most expensive, apprenticeship around, and we kind of learn from our peers. And that doesn't always mean that we learn the right way or the best way. And sometimes, we don't know exactly what other people are doing or what the possibilities are. And with sharing of information, we can show that, and then make changes to use less instruments to be more efficient. And that's part of what we do, is bring that experience to other surgeons.
I want to touch on a question that's popped up with regard to driving efficiency in the OR. Is that a key element, or is that a result of what happens? And the answer is both. So focusing on, as Herb is talking about now, for example, lean instrumentation or specific training of the OR team with regard to reducing steps or speeding up elements or segments of the work that's being done perioperatively. Those are both efficiency objectives and the overall result of this more holistic sort of global approach that was being described by Bill and Herb a moment ago. Both of those things result in greater efficiency. So the answer is really both individually and both collectively. What I'd like to do now is take a moment to look at a couple of interesting case studies. Herb, maybe we could start off talking a little bit about our work at Sutter Health at SacGen, which was a very interesting experience for CAVA, and then the many years that we worked inside of the Catholic Health system and what we experienced there. So maybe we could take 2 minutes on each. Let's talk a little bit about SacGen.
Yeah, that was interesting because it wasn't just focused on robotic surgery. It was Sutter is a large healthcare system that people might know about on the West Coast. That healthcare system is divided into regions and areas. And in the Sacramento area, they had 2 hospitals, Memorial and Sacramento General. And so not only were they struggling with the robotics program, but they were merging hospitals and implementing Epic all at the same time. So we went through that process with them and touched, quite a bit of their efficiency of combining surgery programs. At the time, the chairman of the department was a naysayer. He was a very good laparoscopic surgeon and was not a believer in robotics because of the outcomes that they were experiencing. But once we made some changes on efficiency and the speed of the cases, and it's not just the steps of the case, but the whole team, getting in the room, going to sleep, getting positioned, getting set up, waking up, getting out of the room, the turnovers, and we improved that whole process. Now, many years later, he speaks nationally for the American College of Surgery on the value of robotic surgery and the value of robotic surgery programs, approaching it not in an ad hoc or reactive way, but a very, methodical, planned way. And of course, they experienced cost savings and efficiency improvement, and beyond building a robot program, merged 2 hospitals and medical staffs. Catholic Health is a 4 or 5 hospital system in Western New York. And they had this incredible open mindset of, we want to learn the best practice efficiency and the best practice quality. And they had very, very good data. And there were quite a few outcomes there, including showing that both in inguinal hernia and benign hysterectomy, that robotic surgery could be more cost effective, faster, more efficient, lower costs, better outcomes. And that resulted in a publication also of their transition to robotic surgery from laparoscopy.
Okay, Jim, You have a chance to give a little bit more detail now to your experience at Munson.
Yeah, those were the good days. Those were the good old days. And so look back on that fondly with that team, and that team's still in place over there. Yeah, we brought this in. We spent a lot of time educating our staff, our OR crew, our surgeons were sent off to training and proctored and so forth. And our administration was very tightly involved in the whole process. They would attend the governance meeting, the committee meetings. We had a great robotic coordinator. And we had these goals set out for us, and we talked about them all the time. And obviously, we talked about them in a robotic committee meeting about how much can we improve to get from X to Z here, or A to B in the right direction. And turnovers, cost of cases. We used to joke about this a lot. Trying to get down, we'd have somebody using a certain type of mesh that was a little more expensive, and so forth. And when you're doing ramp up, that's one thing. But once you get up and running and under steam, there's so many opportunities to cut cost and build that efficiency. And that's what we did. And we talked about it even outside, as I said, outside of the committee meetings. It was just a great example. And again, people on the team were trying to make it better. They were very much invested. They were very much owners of this process, whether they were the scrub techs, the surgeons, or even housekeeping that was helping with turning the rooms. Did a great job there.
So I want to say that when you think about building a best practice program, what Jim Flickerman is describing here is a team approach really on steroids. These guys, they were the poster children of following best practice protocol, and they received an incredible compliment from the vendor, Intuitive Surgical, who said within the first year, these guys were in the 90th percentile of efficiency performance nationally. As a small rural hospital in Michigan, just an astonishing achievement. So the point is that even a small local hospital can have tremendous results when these principles are implemented. When you think about a much larger application, our work at UNC Healthcare is a good example. We actually placed a First Assist robotic coordinator inside of the hospital's work in their main hospital. During the first year alone, just in terms of case efficiency, supply efficiency, and so forth, we're able to identify well over $2 million worth of savings for them. It's just a tremendous eye-opener for the UNC main hospital. These are the kinds of results that best practice applications typically result in. So one of the things that we have offered to all the attendees of the webinar would be an assessment of your robotic program. Where does it sit on the continuum of maturity? Where does it sit on the continuum of best practice? We are more than happy to look at some of your robotic console data, and we would be looking at instrument use and console times and give you some insight in terms of what that data offers relative to improvement, quality, efficiency, cost effectiveness. We also offer a 2-day on-site, low-cost exercise, which results in a very detailed report. And that report looks at all 21 dimensions of your program, and it can be credited towards an engagement going forward should you decide to do so. I just want to emphasize that the console data that you already have inside of your own robots is a very, very important source of truth relative to instrument costs and usage across your hospital's staff, and it offers you some opportunities to gain some insight that very few hospitals actually even know exist. Herb, can you speak a little bit about that console data? Because I know that it comes up constantly and people say, I didn't even know that we had access to this.
And there are some reports that can be run out of the customer portal, and that will give you very precise instrument utilization because nobody is entering that information. It's not subject to, GIGO, garbage in, garbage out. It's collected by the robot, and that can be exported and analyzed There's other reports in there that are very helpful. And if you're unaware, on a surgeon basis, about, I'm going to guess now, maybe 50% of the surgeons in the United States at the end of their case or over a week will get an update in their phone of exactly the instruments they used and where they sit relative to some benchmarks. But so this is not PHI. This is, shared outside of the hospital with your surgeons who may or may not even be employed by the hospital. And so the hospital can have insight into that data too for all their surgeons. And that's what we want to look at as a first step.
A couple of interesting questions have popped in, I think maybe triggered by your comments. And one of them is that hospital here is saying Intuitive helps them run their robotic committee. That's fairly common, by the way. The question is that best practice? Is that a good thing? Can we talk a little bit about the role of vendor independence relative to a hospital having command and control over its own program? Bill, Jim, Herb, any of you guys want to jump in here?
Yeah, I mean, really quickly, we have service lines at our hospital. I don't know how other hospitals are arranged on the call, but so each service line runs their own service line. The hospital runs those. We don't have for example, in our spine surgery line, we don't have the vendors who create the instrumentation and everything else running those committees. And what it does, what that concept does is it gives you control over exactly what instrumentation you're going to use and how your surgeons are going to perform. It gives you the ability to do peer review data with your surgeons to help with your quality improvement program and so forth.
Right.
I think that's a really good point. I never even thought about that. How many hospital systems allow or disallow now, like, pharmaceutical rep lunches and those sorts of things? They're just not allowed in the hospital anymore because of conflict of interest. And, that should probably apply to surgery too. You don't have Ethicon in your lap program, or, they don't come to the meetings. And so many times I've seen Intuitive say, oh, this is the Intuitive Robotic Surgery Committee. Well, no, not really. It's the, Community Memorial Hospital Robotic Surgery Committee meeting. So I do think everyone needs to, there's a place for it. And no doubt Intuitive is a leader in, the world in computer assisted surgery. And there's really no equal to them, yet. And not even in the near horizon. So I would think that's a really good analogy of not allowing them in other committee meetings. I think it's also important to remember they're a sales organization, and that's why we don't allow other pharma companies and device manufacturers in there. It's because their focus is sales, and our focus is being good stewards of our supplies and good quality in our surgery and appropriate patient selection. And so I think you utilize and call on Intuitive when you need them for things, but at the same time, you have to be in control of your own ship.
Yeah, and that was my experience and our experience at our hospital as well. There is certainly some value that Intuitive brings, particularly to a startup program, but you got to keep it at arm's length, the relationship, and it's got to be reasonable. And it is your hospital's robotic committee, and not theirs.
It's a great series of comments, gentlemen. Let's talk a little bit about data. There's another question that's come up about a hospital system that has an Epic EMR. And the question is, how challenging is it to get their data analytics to a high level? How long does it take? Herb, this is something we've dealt with at CAVA many times. Maybe you could address it briefly.
Well, of course, because Epic's really one of the most common EHRs in the U.S. Approaching the world now. They're international. And we have some really deep Epic resources. I practice in Wisconsin, and Epic headquarters is not too far of here, and it's no different than, say Silicon Valley. People have access to good Google employees and good Microsoft employees. So we have a lot of Epic experience at Kava just because they're in our own backyard and know how to get that data out of there.
So the bottom line is it's very rich, but there's also a lot of data interoperability problems that we see. And ideally, you also want to be connecting your EMR data with your cost accounting data, and you want to also source of truth with supply chain data or console data. So there's a variety of data sources that you want to draw in and bring all together. Ultimately, that results in performance analytics at the surgeon level, at the case level, service line, hospital system. You can bring it macro or micro, depending upon what your objectives are. And it's that level of data that helps drive a robotic program. It is also data that really distinguishes robotics from laparoscopy, because laparoscopy did not get birthed in an environment of data, whereas we have that environment now with robotics.
I would add that there's another distinction with the vendor, and that is the vendor has great access to your robotic data, but not the rest of the EMR and supply data. So there's a lot of opportunity in, like Bill said, other instrument selection that isn't robotic instruments, or other mesh choices, or the other supplies that aren't intuitive supplies used in the case. That all lives out of Intuitive's reach, and is something that you have to manage with your own EMR, financial, and supply data.
So we've got about 5 minutes left, and another question has popped in, and it actually sort of relates back to the first question we received about OR efficiency and driving OR efficiency as part of best practices. The question is, why is a robotic coordinator so important to a program's success?
Well, I'm a pilot. The robotics coordinator is the air traffic controller. They know what's going on, and they can communicate well with the surgeons. They also are part of the OR crew. Yet a robotics coordinator should have some administrative hat with access to decision support and data. So they kind of get to be the hub of everything going on.
I would agree. That's so important. They are the hub. They are the liaison to all the moving parts of a robotic program. And you got to have somebody that can wear many hats, multitask, and really, there's just no part-time way to do that type of job when you're working with a large robotic program. They're essential.
And really, from my aspect, think of who makes up really your robotic surgery program or your service line. You have surgeons, you have administration, of course, you have anesthesiology. It even goes down to sterile processing, the OR staff, the nurses, the techs, the assists, pre-op and post-op, and even ESD, even your environmental services, your cleanup crew, if you will. And that all has to be coordinated. That is definitely a full-time job.
Yeah, getting all these pieces to fit together is an enormous responsibility. And I would also add that the flip side of this, when we've looked at hospitals and hospital systems without robotic coordinators, they tend to struggle on a lot of these points. They may be okay, but having a robotic coordinator eliminates barriers to performance that lead to so much better efficiency and so much better quality. In every case, the robotic coordinator brings tremendous value to the fluency of the program. So we would highly recommend a robotic coordinator be a very important consideration in any robotic program. And frankly, when you get a system thinking about a system level robotic program. So in other words, you've got, for example, a hospital system with 6, 8, 10, 12 different hospitals with robot programs. Each individual hospital will have its own robotic coordinator, but there needs to also be a system-level robotic coordinator, because the amount of communication that's got to flow from top to bottom and bottom to top, as Bill has been talking about throughout our discussion, and I think Jim very aptly described at his Munson Hospital, it's crucial, and it doesn't happen effectively with the C-suite. Typically, they're too busy. They have too much demanding on their bandwidth. And the surgeons, even the chairs of the departments, they may be independent. And even if they're employed, their bandwidth is limited. They have huge clinical responsibilities. So the robotic coordinator inevitably is a very, very important part of the equation. Okay, I think we're about out of time. We will wrap up then our series at this point. Thank you all so much for joining us. If there are no other questions, and I would encourage everyone to please reach out to us if there are any follow-up questions. I believe there is a follow-up email that will be sent out to attendees today, but we want to thank everybody for their time, and have a wonderful summer. And if we can be of some help to you, we'd love to hear from you. Thank you all.